session. So next, it's my great pleasure to invite Dr. Soumya Narayanan from Kerala to speak about congenital nasolacrimal duct obstruction. Over to Dr. Soumya.
Good morning all. Thank you Dr. Fairoz for this opportunity. Today I am going to talk about congenital nasolacrimal duct obstruction. So I'll be going through a few case scenarios. This is a 5-month-old boy, came with watering and discharge since first few weeks of birth. On examination there was purulent regurgitation on pressure over the lacrimal sac area, and there was retaining of the fluorescein dye more than 5 minutes after installation. So this is a case of congenital nasolacrimal duct obstruction, which present in the first few weeks of life, and the prevalence is noted to be 6 to 20% in newborns. And the most common cause is incomplete canalization of the distal NLD, retaining a membrane at the valve of Haisner. So it's present with the triad of watering, discharge, and matting of lashes, and the signs include increased tear film height, positive fluorescent dye disappearance test, and Roplas. So it can be either simple CNLDO when there is a membrane, only membrane at the valve of Haisner, and it can be complex when there is diffuse stenosis or fibrosis and there is bony abnormality. The CNLDO variations classified by Johnson-Wobbing. The first one is the NLD entering at the vault of the inferior meatus. Second one is a buried probe, and third one is the impacted anterior end of the inferior turbinate. And NLD ending blindly at the anterior end of the inferior turbinate, maxillary wall, and complete absence of NLD. So we should rule out the associations like Down syndrome or craniofacial abnormalities and other differential diagnosis of watering and discharge in a newborn like glaucoma, conjunctivitis, and epiblepharon. So for the management, as there is high rate of spontaneous resolution, 90% of the babies becoming symptoms-free by their first birthday. So till 9 months to 1 year, we can follow a conservative treatment, including simple observation, massaging of the lacrimal sac, and topical antibiotics whenever there is supra infection. So for the patient, we can follow the management. And Krigler's massage, the finger is invertly pressed against the lacrimal sac to elevate the hydrostatic pressure inside the sac and the NLD. We should demonstrate it to the parent and ask them to do it 4 times per day, each time 10 to 15 strokes. So this is a 15-month-old baby. You can see the fluorescent dye disappearance as positive and increased tear meniscus. This is a failed case of conservative treatment of CNLDO. So this baby is an ideal candidate for lacrimal probing with or without endoscopic guidance. So under general anesthesia, the punctum is dilated, syringing is done. You can see the regurgitation there. So adequately sized probe is taken, first vertically, then horizontally, and again vertically. Now the probe is in the NLD, and you can see the passing of the obstruction. And once we get the opening, we can dilate the opening. And this is the repeat of the syringing test. You can see the fluorescein in the nose. And we have to check for the patency of the other eye also. And this same procedure can be done under endoscopic guidance. You can see a membrane at the valve of Haisner, and the probe is coming out successfully. And syringing is also patent in that case. So there is a debate going between early probing and late probing. Early probing is really indicated in case of sac dilatation, recurrent acute acrocystitis, and when there is a need for intraocular surgery like congenital glaucoma or cataract. It's done usually in 6 to 10 months of age. Late probing will give more time for spontaneous resolution and usually done after 9 to 12 months of age and under general anesthesia. And if the first probing fails, we have to roll out complicated CNLDO using nasal endoscopy, and each kind of NLDO has to be managed separately. And we have to repeat the probing after 3 to 6 months of the first probing. We can also try lacrimal intubation with silicone tube, balloon dacryoplasty, and if everything fails, dacryocysto or rhinostomy. And in these cases, the age and the type of CNLDO will give the prognostic factor. So lacrimal intubation either with bicanalicular or monocanalicular intubation, and is avoid annular obstruction at the and contraction inside the NLD during the wound healing. The success is found to be 86 to 89% in different papers. Balloon acroplasty is also a alternate option, if mainly in failed probing or silicone intubation, and the success is found to be 57 to 68%. Here we will do a probing initially, and again we will dilate the NLD using the balloon catheter. So this is a third case where a 4-year-old baby presented with RHO+ positive. There was no prior treatment, so we went ahead with a trial of probing and intubation. And if also we can also try tracheocystoplasty as the patient is little old. And if everything fails, last resort is DCR, endoscopic or external. This is a 20-year-old baby with well-defined cystic swelling in the medial canthal area. This is a case of dicrocystocele, where there is a cystic bluish swelling of the lacrimal sac and accumulation of fluid because of the ball valve mechanism. There is block in the NLD and also a functional block in the common canaliculae area, producing a cystic swelling of the lacrimal sac and also a intranasal cyst. The intranasal cyst can be either small or large. If it is large, it will produce breathing difficulties. So we have to rule out intranasal cyst in all cases of dicrocystocele. So we can give massage and antibiotics as the treatment. Most of the patient will resolve with that. Our patient resolve with that conservative treatment. If it is failing, we can go for probing and endoscopic and intranasal cyst marsupialization. So to summarize, up to 1 year we can continue a conservative treatment, and the type and later if it fails, we can go for depending on the type and age of the patient, we can go probing, silicone intubation, dacrocystoplasty, and nasal endoscopy has a very much important role to finding out the actual cause for the patient and also in the management. And if everything fails, the last resort is DCR. Thank you.